Good afternoon. This is a very special symposium in this context, and it's called Innovative Financing, Lessons from Health Microinsurance in Africa. So the symposium is covering a real large thematic spectrum, and we are presenting with eminent participants new analysis on the evolving field of innovative health financing, using new and already tested approaches and instruments for international as well as for domestic health financing. The interest in innovative financing started around the millennium turn, when the Millennium Development Goals were defined. And you may also know that an eminent international task force was instituted looking into international innovative health financing for health systems. And our first speaker, Professor Atun, will focus on methods, instruments, and achievements in that regard. On the demand side of health financing, global interest has risen regarding various forms of health insurance, which is characterized on the one hand side by pooling of funds, but also of risk, and by prepayment systems, contributions as opposed to out-of-pocket payments by the sick people. We will look into experiences with microinsurance schemes in Africa, and perhaps as a comparison also in India. And we will also learn from national health insurance approaches, in this case from the national health insurance in Ghana. We are having 5 speakers. Each of them will have about 10 minutes for presentation, and we will allow for direct questions after the presentations, and will summarize in a podium discussion in which the audience is invited to contribute. So the first speaker, Professor Atun, has a long experience with the Executive Committee of the Global Fund at the time, but he is now with the Imperial College in London and also with the Harvard University. Professor Atun, he will give us an oversight of the international approaches.
Thank you, Mr. Bichmann, and good afternoon. It's a real privilege to be here today to speak about innovative financing. What I would like to do is to very briefly share with you some of the research we have done in relation to conceptualizing innovative financing and locating innovative financing mechanisms and also instruments that are currently available in the innovative financing landscape. And I'll try and illustrate my presentation with specific examples and try and quantify how much funding has been raised. I'll focus initially on the internationally mobilized external innovative financing, and my colleagues in the audience will focus on some of the domestic initiatives, some domestic innovative financing initiatives that have been able to mobilize funding. So, innovative financing, when did it all begin? Well, the impetus for innovative financing came in 2000, really, with the UNGAS and with the Millennium Development Goals. And that created the momentum for generating additional monies in overseas development assistance. But soon, 2 years after the UNGAS and the MDGs, the Monterey Conference in International Development Financing realized or concluded that funding from domestic sources or from overseas development assistance from traditional sources will not be sufficient. Hence, one had to look for new sources of financing. The term innovative financing was coined. Now, the momentum is carried forward, and hopefully we'll do so with the Sustainable Development Goals. But in relation to domestic innovative financing, there's now a strong momentum because of universal health coverage, the big push from WHO and other agencies. But one of the challenges with innovative financing has been to define it. And without the definition, one cannot really quantify how much money has been mobilized. So we tried to conceptualize innovative financing in a paper with my colleagues at Harvard, Julio Frank and Phyllis Chanol, a paper published in 2000 in The Lancet. We tried to conceptualize innovative financing using a value chain approach, whereby there is innovation around resource mobilization, innovation around pooling these funds, innovation around channeling the monies that have been pooled, innovation around allocating the resources, and innovation around implementation or using the funds to encourage implementation, particularly resource-based financing. Our analysis was interesting in that it identified 3 mechanisms only, in spite of the discourse and the noise around innovative financing and the need, 3 mechanisms that had reached global scale. And these are Gavi, the Global Fund, and Unitate. And these 3 institutions have global footprint, and they've managed to raise large financing and been able to operationalize themselves with success. And the key characteristics of these 3 institutions were, A, they were very inclusive, i.e. they involve multiple stakeholders, including public-private partnerships. In fact, all 3 mechanisms are public-private partnerships themselves. They mobilize funding from multiple sources, diversify the funding base, and they operated along the whole value chain. That's why we call them mechanisms as opposed to instruments. And they were able to rapidly channel the funds that were mobilized into low and middle income countries to expand access to medicines, diagnostics, as well as health services. But looking at the proportion of funding these 3 mechanisms mobilized in terms of traditional financing, innovative financing, we see a slightly different picture. Gavi has been very successful. The innovative financing is actually at the bottom, and traditional financing is at the top. So Gavi has rapidly increased from 2006 its financing from innovative sources, which accounts for a large proportion of its income. Whereas with the, sorry, it should be other way around. It's the dark part is innovative financing. Whereas with the Global Fund, it's a very different picture. Bulk of the funding for the Global Fund actually comes from traditional donor funds, traditional donor financing. Innovative financing, a relatively small proportion of the overall funds mobilized each year. Whereas Unitate has been, again, very successful in mobilizing funds from innovative sources, which accounts for the largest proportion of its income going forward. So this was looking at international financing. One can classify innovative financing in terms of value chain, but also in terms of global and domestic, and what they are used for, general or targeted. So for example, at global level, debt to health, an instrument like debt to health, or either buy-downs will be used for general purposes, or there'll be targeted investments such as affordable medicines facility for malaria, or IFM for immunization, or advanced market commitments, again used for immunization. And there are a number of local domestic instruments that are emerging, such as microinsurance from India and Africa. Pakistan, there's a very interesting initiative called Heartfile, and highly targeted insurance through mutuals, which Rwanda was able to utilize funding from the Global Fund to expand access to the poorest segment of its population. And Grameen is also using new microfinance initiatives in Bangladesh and other places to expand healthcare. So in addition to mechanism, we tried to map the instruments used to mobilize or channel funds. And what we found, and this is a study that is currently under review, what we found is that many of the instruments are actually for resource mobilization. These include, for example, the International Finance Facility for Immunization, advanced market commitments for pneumococcal vaccine, product red, debt to health, World Bank Investment Partnership for polio, Gavi Matching Fund, and the Airline Solidarity Levy, which is used for Gavi. Then, instruments along the pooling, channeling, and resource allocation, these are pooled by for example, Airline Solidarity Levy is pooled by and channeled by UnitAid. Product red and debt to health revenues are pooled by the Global Fund and channeled by the Global Fund. And revenues from IFM and advanced market commitments are mobilized and channeled by Gavi. And in relation to implementation, the World Bank Investment Partnership for Polio Eradication and Japan International Cooperation Agency ODA loan conversion for polio. So instruments are predominantly located in the mobilization, less so around pooling or implementation apart from the three mechanisms. So what are the opportunities and challenges going forward? Well, the opportunities are that, A, there are three proven mechanisms, and we've learned a lot from what works, also what doesn't work. Looking at the literature and the landscape, there are many, many initiatives that have not really grown adequately in revenue terms, but also in geographic terms, to be sustained over time, whereas the three mechanisms I mentioned are thriving. The other opportunity, some of you may disagree, is that it's the declining traditional development assistance for health, which means, on the one hand, this is bad news, but on the other hand, this will spur us to look for new sources of financing from innovative sources, and this should stimulate innovation. And the third opportunity is with the universal health coverage movement, great opportunity for domestic innovation. But the challenges are real. What we've learned in the last 10 years is that, A, there are multiple initiatives, yet few effective mechanisms or instruments. Only three mechanisms that have reached scale, and as I demonstrate to you, few instruments that one can really talk about in terms of the large amounts of financing mobilized. There are very large startup costs. And thirdly, volatility. Unpredictable financing is an issue. So just to illustrate my point, and this is my final slide, in relation to Global Fund, this is a breakdown of the funding from innovative sources. As you can see from different sources, the amounts vary, and the amounts vary quite substantially each year. Now, what countries need, certainly to manage conditions such as AIDS, where there's a forward-going obligation of 30+ years for people on antiretroviral treatment, or malaria, where the bed nests have got to be replaced once every 3 years, or maternal and child health, which is an ongoing issue, or the non-communicable diseases, which are chronic illnesses. So one needs to develop new instruments that are predictable, that will provide financing for long periods of time, not for short periods, to ensure that the funding can be utilized to expand programs, but also to sustain them. That said, I'm optimistic that innovative financing will expand, and there's some projections showing that this field could expand as much as $500 billion in terms of amount. And I'm sure my colleagues will give you some examples of how this is going to happen. Thank you very much for your attention.
Are there direct questions to this presentation? Thank you very much. Let me perhaps put one question to you.
Yes.
Because to some extent it may be disturbing if you are not too much into the business of innovative mechanisms. You have mentioned so many different mechanisms, and one of the interesting mechanisms was the traditional funding, which is declining in ODA terms. Do you think this will be reversed?
Good question. Well, it's a $20 billion question, in fact. Certainly, if one looks at the major contributors to traditional overseas development assistance for health, these are the European Commission, the US, And within Europe, we also have bilateral agencies such as UK DFID, Norwegians, etc. Both European Union, Europe, many countries are in crisis. So it is highly unlikely that traditional assistance for health is going to increase substantially. In fact, we have now entered a period of decline. We had a period of rapid rise from 2000 to 2009. Then we had a period where the rate of increase had declined. And in the last 3 years, the amount has actually declined compared to the peak that was reached in 2010. So I don't think we're going to reverse that in the immediate term. But that is an opportunity because we need to sustain the programs that we've been able to scale up. So we need to look for innovative financing sources. And the partnerships that I've mentioned, we have the 3 mechanisms and there are a number of instruments that we can learn from to fill the gap that's going to be created, but also generate more funding.
Perhaps in the general discussion we can come back to this point because, as you showed, in the innovative mechanisms also traditional donor money is involved. So there may be a competition between the uses of the money.
Yes.
We are now coming to the next presentation, which is Dr. Robert Sebak. He may be mentioned as one of the founders together with Jacques Attali of the Action contre la faim, Action Against Hunger, which has grown to one of the world's biggest NGOs nowadays, and this was founded in 1979. On the other hand, he is now Vice President for Access to Medicines, which is a department within Sanofi and not an NGO. And perhaps he is giving us some clues on how this is creating his present work field. He talks about partnerships for innovative financing, the Sanofi Planet Finance Partnership.
Thank you very much, Mr. Chairman. I think one of the big goals of the World Health Summit, not only this year, but every year, is for the patient and to facilitate access to healthcare, access to health for the patient. And we have to find a way, because we know the reality. And to find the way, microinsurance is one of the way, and I will discuss about the partnership. The second point, very often we've seen that when we speak about Millennium Development Goals, the number 8 is partnership. And partnership is something very important because pharma industry alone is impossible and government alone, and we have to build some partnership. And for some specific issue, we have decided to work with Planet Finance, and I know that Jacques Attali will explain exactly what is Planet Finance. And why we work? Because we try to find a way. When you see the reality about access to healthcare and access to medicines, you see that in the majority of the country, in developing country, 80% of the population, they have to pay for the treatment. And it's a paradox, because in these countries, no social security, no private insurance, and they have to pay. And we have to find the way to facilitate access, and donation is not a sustainable solution. It's why we have decided to work with Planet Finance and to see how we can facilitate this access in terms of affordability, in terms of reimbursement, and things like that. First, we have decided to work with Planet Finance on microfinance. Why on microfinance and pharma industry? Because when you give money to some people in Africa, they have to reimburse this money. And if they are sick, they can reimburse. It's a common interest. And mainly in Africa, where malaria it's a very important problem, and it was important to explain to the mother the risk of malaria and how to prevent malaria and how to treat malaria to reduce the number of days absent for the job. And we have decided to make a sort of kit of communication, information, education, communication for the mothers in Africa, mainly for the women. It was our first relation with Planet Finance. And after we have seen, okay, why not microinsurance? To create from scratch
an insurance. It's not a global social security, but for some people to give them the opportunity to have access to medicine and to healthcare. Now, my presentation here. Help me. Yes. No. This one.
Okay.
Okay. And through two programs that we have started with Planet Finance, one in Benin and one in Madagascar, just to tell you what we have done. Sorry. The first one in Benin, provide insurance for microfinance institution clients. To say to the people, you want to have some money for doing the job, but you have to take an insurance to cover you in case of problem. The methodology, it was voluntary insurance, and we'll come back on this point, voluntary or compulsory insurance proposed to microfinance clients. Approximately, €1 per month, but only for the client, the chief of family. You will see that in Madagascar is a little different. The customer, rural and urban customers, and health services provided by a state-run institution. This point is a key point, because the people, they are ready to pay insurance if they have good service in terms of health. It's why you have to check the quality of health, a consensus to treat the people, they have drugs, no drug, good doctor, no good doctor, to make some training. If not, they will pay for 1 year and after they will leave. It's why it's very important to check the health services. In Madagascar, it's much more sophisticated. We have 2 microinsurance health programs. One of microfinance institution in the capital, in Antananarivo, and another one with some people, producers of vanilla, on an equitable business. And we try, and we finance this program, to reach equilibrium and autonomy of this project around 2016. What is the methodology? It's a common platform created to manage the 2 projects. Just one, we regroup the platform. Microfinance institution clients is a compulsory. When they need money, in the same time, they take an insurance. And all the loan, more than €350, they pay for all the family, the insurance, health insurance, €9 per family and per year. And the same, we want to cover 30,000 people around 2016. For the second one, for the family vanilla farmers, health insurance is a little more expensive, it's €29 per year and per family, but paid by the customer, by the people they bought the vanilla. It's different. And we want to cover around 7,500 people around 2016, and already we have 1,500. It's not a dream, it's already on the field, and I was myself in Madagascar a few months ago to check and to see the reality of this project. What can we learn of that? And as pilot project, and I know that Planet Finance, microinsurance, you have some other projects, but this pilot project is a very important one, because we have learned a lot of things. First, we have to be very simple for the people. We thought that compulsory insurance is simpler for customer and for the institution. In the same time, you say, okay, same time you have a loan of money, but you will have also the health insurance. It's a 1 year payment for 1 year to cover. It's much more simple, administratively speaking, than every month, or voluntary payment. The coverage extended to families is much more attractive than if limited to only one customer. Most important point is provide quality health services above local standard care. Because they have to see the difference. Because we give a service to these people, and this point is very important. One is why we have to check all the health centers to be sure that the service will answer really to the needs of the people. But at the same time, you have to give some health education in addition to insurance coverage.
promote the need to see a health professional. It's a lot of automedication in this country. It's why it's very important to give them, and they have to see the difference when they go in the health center. And with all these points, I think now we have a design of what will be really a very good to cover the people in terms of health. Is a key point. You know that if we want to improve access, we have to find innovative financing, existing already global fund, but it's only for TB, malaria, and HIV, even for United, but we have to find some other way, you know, for some other diseases, non-communicable diseases and diabetes. Why not oncology? Because it exists in the South, mental health, epilepsy, many other diseases. We have to find the way before perhaps something much more organized by the states to have a social security in the level of the states. But it's not the case in many countries today. This is just an experiment, pilot one. It seems to work very well with very good results. And I think in one step forward to reach access to healthcare to the majority of people. Thank you very much.
Thank you, Robert. Questions from the audience? 1, 2. Ladies first.
Yeah. So my name is Yamila Castro. I'm a journalist. I'm French. I wanted to know, you say that you need to you need to provide high quality health service, but how do you do that? I mean, are you working together with the government, with institutions? Same for the education. Are you working maybe with the school system? And since when are you running this project? And is it profitable with these very low rates for the yearly insurance? Because also the family, you say that this is an amount that covers the whole family, and sometimes the families, especially in Africa, are very extended. So that could mean lots of people in just one family. Thank you.
This is the key concern of this project. But you know, we have to find a win-win situation. Good for the family, but also good for the doctors of the health center. Because in the same time, you will provide to the health center a group of people, they will work. And also you have the money. Not all the family will be sick in the same time. This is the principle of mutualization, the principle of insurance. And with that, you insure to the health center, but you have to check the different health centers to be sure they will provide good services. If not, it's finished. And they see the interest because you insure a group of people, you insure training, you insure education, and the main task for the people, and I've seen in Madagascar, is to go around, according to the customer of health insurance, microinsurance, to check the health center and the quality of health center in terms of providing drugs and so on. And our support, and the support of Sanofi, is also to fulfill the gap between the needs and what we have to give to the center according to the reality that we face today when there is a lack of many things. To give a higher level in terms of health, in terms of services provided to the people. But it's not an easy task. But we have to, I told you, to find a win-win situation. If not, again, if the people, they don't find good services, they will stop the insurance.
Second question. I think the gentleman here.
At the same time.
Sorry, hello. My name is Abakar Kurifi. I'm working with the National Health Insurance Program in Nigeria. My question actually has to do with the issue of, it is one thing to raise the money, pool the resources, but also the capacity to manage these resources and bring out programs that will actually be sustainable is one thing. For example, one of the issues that we're facing with micro health insurance in the communities, is the issue of the capacity of the communities to manage this money and even manage the health systems that you have on the ground. So I want to hear from you, how are you able to, what is the management structure as far as the program you are rolling out is, and how are you able to actually, achieve the success you're actually showing? Thank you.
Robert, may we take the third question immediately?
My name is Sunur Verma from the Geneva Health Forum. I have two questions for you. One is, as Sanofi, as a pharmaceutical company, don't you feel there's a conflict of interest in you engaging in insurance in a low-income country? Second is, I'm repeatedly hearing this call for finding extra money, either by creating new services, etc. Have you, as a company, explored or running an anti-corruption campaign in a low-income country as a way of blocking misuse of money which can be diverted to healthcare, as that is a big drain on national budgets? Thank you.
Master student in Switzerland. I have a question. What is actually covered by the microinsurance? Which kind of diseases, also service like child delivery, vaccination service, and so on? And you have already found out if like the out-of-pocket expenditures have decreased because of this kind of insurance. Thank you.
Okay, for the first question about the management of the money is managed, I told you now, not for all the population. It's a customer of Microinsurance Institute, and the Institute of Microinsurance makes the management of the money. I told you it's a pilot project, and according to this one, we'll see how we can expand this type of project. The second question about conflict of interest. What is the common interest? The common interest for pharma industry is to find a way for affordability and for access to medicine for the people. We know, I will be very transparent, the growth will come from the south. And we have to see the way for that, to change the business model, to find a way for the patient can have access to drugs, not only Sanofi, but some others. I think this is also the participation of a big company to be a partner of this type of things. Because as an actor of health, we have also some responsibility. And the money, because you speak about some corruption, again, the money is managed by the Institute of Microfinance now. And for this one, we have checked, and it's going well. We'll see tomorrow how we have to overcome Institute of Microfinance. But today, we have the insurance that everything is going well through this institute. After, you asked me about the
benefits package.
The benefits package is to have treatment, to have advice from professionals. It's why we need to give a very good service. It could be immunization. Now, again, it's a pilot project. We have to see with €9 per family and per year is enough, because I told you not all the family and all the people will be sick at the same time. When you see today the average expense for health in sub-Saharan countries in Africa is between $5 to $6, $7 per person and per year. Per person and per year with a very bad services. But this is what they spend today. Not in North Africa, not in South Africa. And with this amount of money, up to now we can cover not all, but 80% of the main pathologies that we can meet in the field. But each year we will see if we can cover or not. Perhaps we have to go €10 per year and per family. Perhaps it will be less. We will see. We start. I think it's very important to start to start something and to see what will be the future of this type of operation.
I think we have to stop the direct questions here. This may be a major subject for the general discussion in the end, service level, what is possible with microinsurance as opposed to other forms of finance. Now I invite Professor Jacques Attali, whom I mentioned previously already. He has been one of the co-founders of Action contre la faim, and he has also been one of the co-founders of the EBRD. He is now the president of Planet Finance, and he will give a complementary view to what we just have heard in the previous presentation.
Thank you very much. I have almost nothing to add to what Robert said because we work together on this topic. I would just begin by saying something more about microfinance and what Planet Finance is doing in order to put that into a global context. Microfinance was 15 years ago very small when we began to launch the operations of Planet Finance. It was reaching something like 7 million beneficiaries worldwide, while today microfinance is reaching something like 220 million microentrepreneurs worldwide, which is something like 1/3 of potential clients. And we launched Planet Finance as a global organization to support, by all means, the development of microfinance. To make a long story short, today we work in 80 countries as a non-profit. We have a branch which is doing technical assistance. It is in this dimension that we work with Sanofi on health insurance. We have also a branch which is a rating agency, and we are one of the first rating, if not the first rating agency for microfinance institutions in the world. We have we are also partner on a fund of $1 billion to provide credit lines to microfinance institutions. We have our own networks of banks, of microfinance banks in more than 10 countries, mainly in Africa, Senegal, Madagascar, Ivory Coast, etc., Nigeria, etc., and in China. We have also an insurance broker to provide mainly crop insurance, also death insurance, and some other dimensions of microinsurance also worldwide. We have also a company dealing with mobile financing, which just began in Philippines, and also we work on microfinance in the developed world. We provide microfinance advice and funding for people in the main cities of France, and now we begin in Italy and Greece. That's in a nutshell what we do. We do also many other things, including crowdfunding website called MicroWorld, where you can go and provide a direct loan to a direct small entrepreneur, which is identified, and you can lend 20 or 30 euro to this man and get details of what he's doing and get reimbursed at the end of the year. We began to work with Robert and Sanofi many years ago on health, around 2007, on health, and the first program that we had was to provide tools for prevention, saying that when people come, and mainly women come to a microfinance institution to get financing, it's a good place for them to get also other advice, because microfinance banks are not here only to make a loan, but also to advise how to deal with a project they have, which is handicraft, agriculture, whatever. And then we can add an advice on something else, which is health. And we did that in Benin, and it worked quite well. We did a lot of training for microfinance customers on malaria, and it works quite well because it was a very close relations between the women borrowing and the training. There was not a compulsory, we could have said, okay, you will not get a loan if you don't train on such and such techniques, mosquitoes, etc., etc. We didn't do that, but there was a strong incentive to do it, and that worked quite well. Later on, we went, as Robert said, to provide insurance scheme for women in Benin, and then to do that also in Madagascar. And we have also a third project which is going on in Nepal, which is mainly focusing on microfinance solutions of 30,000 microentrepreneurs, providing a premium insurance paid by the microentrepreneurs, mainly for death insurance and 2 illnesses, which are kidney disease and cancer. That works for a premium of 40, equivalent of 40 euro. The lessons that we take out of that is that it worked quite well. It is, as Robert said, different from one to another. It's much more efficient when it's compulsory. It's of course much more efficient when the value for money is here. It's a question of the quality of services. It's why we have to work with the government in order to provide a good institutional environment and good services on health given by the health centers around. We also have to, and it has been mentioned, to have a good system of money transfer to be sure that the money, which is small amount, as you have been told, is really received and can be received from remote area. It's why mobile banking can play a role, can be very efficient and can be used. And we also have to work differently according to the culture. There are some cultures where people don't understand even the meaning of death and being covered. Death is a natural element and illness also. Why do we need to cover for that? While for us it is important because the main reason why we enter into this field is that according to all the studies, microfinance is good to help people to get out of poverty, but as soon as people get out of poverty by having a job and being able to finance his job through microfinance, wherever he is ill, he go back to poverty because rule of thumb, the cost of health is 50% of a yearly revenue for a family. Therefore, it's out of question. If you don't have an insurance system, health can kill any efforts to get out of poverty in any circumstances. Therefore, it's key to reach a point where microinsurance can be linked to microfinance. And unfortunately, while 220 million people are covered with microfinance, the coverage on microinsurance is much lower. It exists in India in a very specific context. It exists in some countries, but not with a lot of development, while we believe that it can be done with a lot of efforts and should be a priority because the cost is very low, the potential of success is very high. We have seen that in other insurances, such as crop insurance, which is wonderful success today. We see that in a lot of other countries. It's a matter of putting that within the plan of governments, the health departments, the money transfer system, and also to be conscious that it's different from one country to another. As I said, there are some countries where people don't care about death or illness. There are a lot of countries where people say, okay, I pay my premium for this year, I have not been ill, therefore you use the premium of last year to finance my health problem for next year, which of course is not the way insurance works. But it's hard to explain the nature of the probabilistic system that health represents for many group of people. Therefore, it's a long process. I am very often quite frustrated that we do not succeed to get quicker in the development of microinsurance, but it's certainly a must and should be more a priority for donors than it is today. Thank you very much.
Thank you for this good insight and demonstration that microfinance institutions develop their own interest to provide also insurance for health issues once they have customers. And this may also be a model for other industries which may provide health care for their clients. Are there some direct questions? If not, there's one.
Hello everybody, I'm Dr. Salima Bhatia. I work with the Ministry of Health in India. What I wanted to know was that when you are implementing the program, what is the reaction of the service providers? Maybe I'm not clear on this, but this might increase the workload for the service providers in some institutions. Do they expect a part of the gains? Are there any reactions on that from the service provider aspect? Thank you.
On that, but personally, and as I said, we work with Sanofi and with Robert closely on these matters. No, we have not seen that. It could have been, but in the free experience that we have, we are very demanding on providers, and we have not seen any difficulty on that. But maybe you want to add something?
Okay, then I would invite Ms. Gomati to give us some insight in building sustainable micro-health insurance schemes with the background of India. To introduce Mrs. Gomati, she's Senior Client Manager and Vice President Client Markets of Swiss Reinsurance Company Limited in India. Please.
Relevant to the market where I work. So health is something which is universal, which affects everyone. It's like your air and water, which is relevant to you as much as it's relevant to me. So that's one of the reasons why I chose this as my profession. So it helps that I work for a 150-year-old institution, which is a global giant in any kinds of risk transfer. But when it comes to government-sponsored health schemes, India, which is one of the youngest units for my company, leads the way. So there are some experiences which we have gained in the last 6 years, which I thought might make sense for all of you. So here we go. See, you're going to see some visuals of some people who are connected to each other. You can see it with the way, the photographs are. They're all connected in some form in terms of the kind of diseases they have, the kind of accidents or ill health that they have suffered. And another connecting factor is poverty. So they have all these things because like accidents or disease doesn't knock doors of only people who have money. It comes to everyone. So they have this poverty, so they can't access care. So what is different among these people? So currently, they are all beneficiaries of government-sponsored health schemes in India. They can't pay, for any kind of inpatient treatment. But currently, if you see this 1-year-old kid, it had a heart replacement surgery. So this kid belongs to a daily wage earner whose father earns less than $1 a day, so can't afford a treatment which is as severe as a heart surgery. So what has changed the kind of lives that these people lead, and how does it affect all of us? So one of the things where I think India leads the way is a public-private partnership. So I definitely understand that everything cannot be commercially viable and should not be measured in terms of money. But for the sustainability's sake, if you see, there are some funding mechanisms which we need to take charge as citizens of each of our country and develop an ecosystem which makes sense for that particular country. So if you look at what are some perspectives which others can learn from India, over the last 6 odd years, there has been a good, sustainable insurance scheme which has been going on in India. There are 2 of the schemes which Swiss Re is involved in, which is what I've articulated. One is the Rashtriya Swasthya Bima Yojana, that's a Hindi word for National Health Insurance Scheme, which is, there are 28 states in India. So this is for the really below poverty line people who earn less than $1 a day, less than $1 a month, and then it covers the base-up surgeries. If you understand the way morbidity risk products are structured, someone who gets admitted in a hospital for inpatient care for their primary and secondary care. So if you look at the cost, the kind of families who are being treated under these schemes, we're talking about RSBY, which covers something like 34 million families across the country. So in terms of number of lives, you can multiply it with 3, because 2.9 is the family size. So we are talking about, if you look at India, it's like comparing 28 countries put together. Everything about every state will be different. The kind of infrastructure in terms of medical hospitals available, the kind of admin system which needs to be put in place, everything is different. So it's about a scheme which is connecting 25 states and which covers 34 million families. And the kind of scale-up time that it has taken, it's hardly anything at all. It started in 2008, and we're talking about 34 million families. So the scale-up happened almost in the first 2 years itself. So most of the states bought into this idea, and they implement something called a tender system. So there are 10 to 13 insurance companies which get involved in each of the bids. We call it a tender. And then the lowest tender, the insurer who has quoted the lowest price wins the tender. But the structuring of the scheme is made so standardized, right from the smart card which is used to the IT system which gets used, it's very standard. So people need to get certified to get into the scheme. And then it's the experience from a beneficiary's point of view is uniform across the country. You can talk about the next scheme, which is a slightly different variant of the RSBY scheme, which is a tertiary care scheme. Secondary and tertiary care inpatient surgeries are covered. Some amount of diagnostic procedure is also covered. It's called the Tamil Nadu Chief Minister's Health Insurance Scheme, which is operational in the South Indian state of Tamil Nadu. So if you look at the premiums, we are talking about $8 a year for a family of 5 members, and a coverage of something like $1,600 a year, which is what it would take for anyone to undergo a heart surgery. So everything about the scheme is cashless, paperless. You have to come and visit any of these project centers to understand India is no longer a world of snake charmers and all non-technological thing. You have to come and see it's a nerve center, how it operates. If a patient comes to a hospital, it's a real-time system which is operational, where the scanned copy of his smart card and everything gets transported for a pre-authorization, which goes to a project office, which has like 100 doctors sitting in the place who are specialists in various functionalities, and they pre-authorize whether medically it's required to take the treatment or not. Once the pre-authorization happens to the hospital, the person gets admitted, gets the treatment, and then once he gets discharged, within 7 days, the insurer settles the claim to the hospital. So whatever information we are talking about is available online, and it's available. Look at the scale of operations. For a single Indian state of Tamil Nadu, we are talking about 50% of the state covered under the scheme, which is currently primarily funded by the government. But if you talk about getting into a sustainability mode, after a particular point of time, if the government wants to introduce some co-payment, wants to introduce the above poverty line families into the thing, it can be done. So the scheme is scalable also. So what can cater to, say, 13 million families can easily cater to the whole of the state, which will be another 13 million families. So what is this whole public-private partnership driven? If you look at it, I think it really has driven the operational efficiency and transparency of putting this kind of healthcare access to the common man. So, see, I'm a medical insurance products person. So when you look at this kind of a risk transfer mechanism, normally my actuaries look at this kind of a curve and see how do we structure some sensible and affordable risk transfer mechanism. So I think it comes down to the benefit design and how much can a government or whichever family is getting covered or groups of families which are getting covered can pay for the benefit. So there are some rules of the game which any policymaker will have to go through. Some of it is what kind of hospital infrastructure is available in the state we are talking about or province which we are talking about. If there is no primary, secondary infrastructure, then they need to ensure they create some infrastructure or at least transport these families to the nearest hospital which is available. A good example to point will be an insurance scheme which has been implemented in the state of Andhra Pradesh, which is again a South Indian state. 6 years back, before they implemented the current tertiary care scheme, I don't know except two provinces where tertiary care hospitals were available. But today, if you go to the state, every single district has multiple tertiary care hospitals. I think one of the way to measure the efficiency or implementation strength of such PPP schemes is to see whether the money is going down to the district level, which can provide access to care of all the people we are talking about. It should not be a paper tiger where we speak about things on the presentations and it has no meaningful sense for someone living in that location. Because when I fall sick, I don't know when I will fall sick. I need hospitals where I can go and take the treatment. So are these schemes facilitating the flow of money into this kind of hospital infrastructure? So that's an important way to measure whether these schemes are successful or not. And the other part will be, what is the kind of claims cost versus non-claims expenses that the schemes are talking about? So normally for a very large scheme, at 10 to 12% non-claims cost, you will be able to structure something sensible. Because you need an administration structure, you need IT in place, you require doctors to pre-authorize. These all things are required for making it very efficient and transparent for the whole stakeholders involved. And that's going to cost money, which will be your non-claims cost. The third part is the anti-selective procedures. For example, there was a case of hysterectomy in India, which became a money-making machine for many of the hospitals which were involved in these schemes, which was a disaster because hysterectomy cannot be, I mean, you can't do hysterectomy for any kind of people. There has to be clear medically necessary reasons to do that. Otherwise, you'll have a whole set of population which will have hormonal imbalance. So there was this problem that we had. So when we are designing government-sponsored health schemes, we have to be very careful because being an Indian, I believe in the truth of karma. So I have to do things which I don't carry the negative effects of it to my next birth. So something like this can really be bad for the whole society. It's better not to have an insurance scheme than have something where the hospitals become butcher's shop, chopping off some of the things just because they make money from the insurance scheme. So there are some factors which, as an insurer, we can put together to make some things which become sustainable. We are talking about one of the instruments, which is public-private partnership. We're talking about few of the elements where I think alignment between different stakeholders is very important. The funding mechanism, we have to be very clear. If the government can fund only for the, if you look at the, this curve, if only major surgeries can be covered, we should talk only about that. That will make the whole benefit design very cheap, and that's the last dollar coverage. Even as a poor family, I can afford to cover for the consultation and small medicines, but I can't afford a heart surgery. If my government can fund only that, the design of the scheme has to take care of that. The other part is the benefit structure, which needs to be sustainable and affordable. See, health is hugely political. You can only introduce such schemes. You can't remove it out of the, you can't close such schemes. So the sustainability part is something which the policymakers have to be really clear about. Otherwise, you'll start something and then it won't sustain. The other part is the robust IT infrastructure. I think this is one main area where India has really shown the way. A lot of transparency can be driven by having a real-time IT infrastructure, and it doesn't cost much. So there are structures available in many of these schemes in India which can really make the scheme very robust, and real-time monitoring can happen. And the other part is it has to be hospital tariff-based so that nobody has to pay anything. It's completely cashless and paperless. And also, you have the fraud management in place because of real-time data available. Generally, if there is money to be made, we've seen hospitals make use of the loopholes. So that is something, fraud management should be in place. That is where an insurance company plays a big role in it. So, thank you. Would be happy to answer questions.
I would propose only one question, if there is one, to this presentation of the India experience.
Phil Fan from Johns Hopkins. So can you talk a little bit about what the overhead costs is to administer something like that? So, for each dollar covered, how much money is spent in the actual administration and fraud detection and all that?
If you talk, I think it has a lot to do with the scale. If you have something like 1 million people covered in a scheme, generally you'll have an overhead expense of 12 to 15%. So if it is something lower than that, generally up to 20%. But a lot to do with the scale that we are talking about and how IT enabled it is.
The important aspect of having a PPP here together with a government scheme, I think that would also be something to be discussed in the close-up. But I would now invite Dr. Neonator, Frank Neonator from Ghana. He is the Dean of the School of Public Health, University of Health and Allied Sciences in Ho in Ghana. Please.
Thank you. Whether I'm going to live up to expectation. But again, let me tell you a story of the fact that Ghana, as a country, we went through 2 decades of user fees model, and you know the story about user fees that create horror stories everywhere. And we reformed our health financing system to develop a universal social health insurance program that combines a central funding, broad policy framework that includes all the insurance parameters, benefit packages and premiums and provider payments, and also ensure that it was decentralized at the district administrative level and financing. This is to empower the districts to manage the service delivery at that level. This decision, again, for us, it was a matter of to hell with it, let's get the business done by the politician. So it was politically driven based on an earlier electoral promise, and the law was established. The law proposed a unique system, a hybrid of both social health insurance scheme and mutual health insurance concepts, defining a classical single-payer scheme for the organized sector, multiple payers schemes for the non-formal, whilst allowing private and commercial schemes also to function. This scheme covers both the direct and cost of health services for both health services and medicine, and for the most common diseases that we see at the OPD. And this is the fund and the proportional contribution that we have towards it. Clearly, we have the contributions taken from the formal sector, which caused a lot of what they call it, uproar in the country, because we're taking out of their retirement benefits, and they didn't like it at all. Then we imposed a 2.5% VAT onto the existing VAT that created most of the bulk of the money But the premiums from the mutual health itself, as you will see later on, is only about 5.1%. Now, this is how the money flows. The levy and the Social Security contributions are collected through the Ministry of Finance and then plowed into the National Health Insurance Fund, managed by the authority, and that provides subsidies to the district mutuals, whilst the premium are collected directly at the district mutual level. And then the expenditures, as you can see, are over there. Has been successful, but the success comes with a lot of costs. Indeed, as I said, the law made a provision for 3 schemes, the district mutual schemes that are being subsidized by government funding. There's the private commercials that are not being subsidized, and then there's the private mutual also that are not subsidized. By 2010, we had about 145 district mutual health that were registered. By 2012, we doubled basically that number to having about 212 mutual health organizations and only a few private mutual schemes. This created a bit of legal dilemma. Indeed, the legal and institutional framework to run independent, autonomous, decentralized mutual health schemes created what we call a system without appropriate layers of administrative and financial oversight, clear line of supervision, and due processes. And this is also complicated by the fact that the district mutual health insurance depended on authority, as I showed you, for most of their funding, including bailouts. But they are also, when it comes to asserting their legal and operational independence, they say, no, 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 you cannot dictate to us. So that legal conundrum became a problem. So as a country, we moved forward and we said, okay, can we address this challenge? So we had to sit and review the act and replace it with a new one that creates a new governance structure that abolishes the district schemes and has set up a national unitary scheme that with the region and the districts being answerable to the authority. That is the recent development of it. And of course, it also broadens, the law also broadens learning from experience, broadens the benefits packet, the people who need to really get the benefits of this scheme. It's included people above 70, vulnerable groups, and others, and also mandated that authority liaise with ministries and regulatory authorities to ensure that we identify those who need the services most. Of course, the new law also has introduced a new conundrum. It indicates that members of the insurance scheme should contribute one installment in their lifetime, what we call one-time premium payments for the whole of their lifetime as a contribution. And that is also very new, and that's generated a heated political debate, which is ongoing now. We haven't found any solution to that one yet. But this is, again, a politically driven structure because it was realized that people were not able to pay. But in operating the insurance scheme, there have been challenges. There have been high adverse selection. There have been huge moral hazards because there's no co-payments, no restrictions on the number of times a person attends facility, leading to facility shopping by most of the clients. There have been increase in service utilization, increased employment to the service providers over the years, but there has been no effective communication between the health insurance scheme and the providers. And that has also created a huge problem. These two institutions are government institutions serving the same clients, but they are not talking to each other. There have been delays in payments to the providers. There have been changes, the way that providers react to new changes. Like if you bring fee for service, the providers added one more service. If you do DRGs, the providers decrease their laboratory investigations. With track capitation, the providers shifted their patients from OPD into inpatients. So at every point in time, there have been challenges in implementing this. But the our biggest challenge has been the fact that when we did actuarial studies some time ago, we realized that if you don't take them, the insurance will go bust. Basically, from the year 2012. And this has been one of the concerns for government in trying to see whether we can raise the VAT. When you see the diagram, you see that the VAT component is the huge contributor. And to raise it from the 2.5% to maybe about 3 or 4%, that is also something that is going on. But all said and done, at least for the mixed survey that we did in 2012, at least 60% of men between 50 to 59 years have registered with the National Health Insurance Scheme, even though only 34% could show valid card. At least there is some level of service provision. And that, for me, is very significant. And so, for us in Ghana, the National Health Insurance Scheme had been driven by the needs of the public-private providers who, in fact, were concerned with the loss of revenue, cost recovery, but we also use existing practices of small credit unions called the SUSU schemes, the experiences, to shape what we have been doing. This was also operationalized by the political considerations, and indeed, I said, unintended consensus, because both sides of the political divide agree that that's the way we should go. So for us, the technical people, we are the most happiest people, because that's something that is actually helping our cause. It has been actualized by learning by doing without a blueprint. I don't know where any country who is actually combining this hybrid of social health insurance and mutual health scheme all together in the same arena. And that is something that we should be documenting as we go along. But the systems work. The system works, and we can improve on it. That, for me, is what I believe. The question I ask myself and ask everybody is that, is this the way forward for Africa, or this is a hazardous experiment that we are embarking on? It's not everybody who is happy about us. Oxfam, remember Oxfam's recent publication claimed that, well, although the insurance premiums are being paid by the informal sectors are subsidized, large numbers of Ghanaians cannot afford the premiums, which range from $3 to $22, that's target. But even this cannot be afforded by most people. Even more than that, it said the Ghana's insurance have been labeled as a success by a variety of write-ups. It is only covering 36%, whilst the rest of the 64% are making out-of-pocket payment. Thank you very much.
Thank you. We have now seen a very wide spectrum, and I think the Ghana example in the end was really giving a close to the questions raised. I would invite you for one question to the Ghana presentation before we go into a general discussion.
Thank you very much. François Bompard from Sanofi Access to Medicines. I'm curious about the informal sector, because to me informal sector means primarily really poor people who cannot pay. I'm wondering about the informal sector.
Informal.
Yes, because to me informal means usually really poor people who cannot afford anything. But how can you be sure that the people who do not pay actually qualify because they are too poor, or is it because they hide from the taxpayer? from the tax administration, I mean. How do you differentiate between people who are truly poor and those who hide from the system so as not to pay taxes, not to pay VAT, and so forth?
Clearly, first of all, the informal sector is simply defined those people who are not employed by government, basically. And it's a whole spectrum of this type of level of being. People who are in peasant farmers and in the communities who don't have any work to do, and people up to people who are in the main cities where they are doing all sorts of commercial ventures, but really not part of the government sector and not paying any tax. Indeed, one of our biggest problems is how do we broaden the tax nest for even the whole country so that at least revenue to government is increased to be able to use for schemes like this.
Can I just make a comment?
Professor Atun.
Just two comments. One is clearly there's an issue regarding, the issue is not just mobilizing and pulling the sources, is how this is managed, how you allocate resources, and what you've also shown in terms of the supply induced provision of services in relation to fee for service, also with per capita payment. You have downgrading of the service quality. So the whole value chain needs to be managed appropriately. And we're seeing two models here. One is that where a private sector institution, such as Swiss Re, in the case of RSPY, that there's institutions compete to get to be selected to manage RSPY. In the case of Ghana, you've moved to a single mechanism with representative offices. So it would be important to document what works and the question regarding what are the overheads, not just running costs, actually, but also upfront investments that have been made in the case of RSPY with the unique numbers and the cards. My second comment related to this very interesting approach in Ghana to introduce a targeted tax in a way, a hypothecated tax, which is 2.5% VAT. Some people might argue that, and we have very distinguished economists such as Jacques Attali in the audience, but VAT tends to be regressive as a form of tax. So what is the sort of justification of using a regressive tax scheme to try and enhance equity? It's an interesting approach. Or maybe Jacques can comment on that.
It is true that VAT is supposed to be not a regressive tax, but an equal tax to anyone, which means that it is equal, whatever revenue you pay the same. But very often it's the only way to get financing, because it's the cost of recovering the tax is lower than the cost of recovering income tax, where you need to know a lot about people, etc., etc. Then there is you can find a way to equalize, to give some kind of equity in the VAT tax by putting different rates, low rate to consumption goods and high rate to caviar and whatever. It's what we do in Europe, as you know.
Another question which we should approach.
I have just one question to our colleague from Ghana. Since the beginning, did you see some result in terms of public health parameters in some diseases, malaria crisis, immunization rate, things like that? Did you see some result? Because it's very important to know if it works or not, if the population that finds some solution to the health problems.
Well, I would say that there are ongoing studies. Clearly, what we've seen over the years now, it started in 2003. We have done the DHS, we have done MIX, which as compared to the previous one, there have been general improvement. But we are cautious not to say that this is only attributed to this kind of thing. Generally, service provision itself has been improved. Global Fund has been increased their money. Gavi has increased their money. We introduced new vaccines. So there are quite a lot of compounding factors, but we need to be very critical to find out what effect has this scheme been on the life improvement of Ghanaians.
I just wanted to ask you for some comment on what is the role of the international innovative health financing issues, and you just gave a partial answer with regard to the vaccines and the role of the Gavi and the Global Fund. So I think what we can draw from this session is also that it is very complex to find a uniform financing approach. You have to have different aspects in it, and the public-private partnership model may create some challenges, but it may also have a lot of opportunities more than uniform systems. But let's ask the audience whether there are some burning questions left from this interesting discussion.
So this is really fascinating because coming from the United States, where there were recently very vigorous discussions about public health insurance, I'd like to particularly hear from your perspective, what do you think are some of the political enablers or barriers to this kind of a scheme? And the Indian experience is particularly interesting, precisely because you are trying to create a scheme for 25 countries, if you will. And I think the US experience, it's probably similar to that.
See, what we have seen from the Indian experience is whatever solution that needs to be made needs to be homegrown. I think a lot of aspects comes from that basic reality. So once you see something work in US and you try and force fit into a country like India, it might be probably adding to a lot of satisfaction from the global fund's point of view, but might not be relevant for someone who lives in that country. See, as an Indian, what makes sense for me? My father stays in a village. The village hospital is fantastic. That makes a lot more sense than what would make sense for you as a sponsor of this program. And what else would make sense for me? I need to be sustaining on my own, not be dependent on you after a period of time. So if you look at the Indian experience, I think the second major cause of rural indebtedness was health. I think that goes with many of the other developing countries as well. So till now, people were there, they couldn't afford their treatment, which was fine. I think we had such a huge population. We couldn't afford 3 times a meal, health came next. But now there are a lot of structural changes which have started happening. The growing middle class with a lot of disposable income is a fundamental different thing which has been a game changer in the last 15 years. So it suddenly started creating, viewpoints where we are very good in IT. How do we make use of that to create that base infrastructure? Real-time monitoring is important for making these things work. So you could marry IT with a lot of good medical doctors and paramedics that we have in the country. And you don't have to be there in all the states. You can have a control room in one place and just make it IT enabled across. So a lot of these things have made a lot of sense. And you always have this feeling that you don't want to replicate some things which are not going all right in the developed nations. So one good experiment will be the US experiment. You can't have a scenario where you start paying $700 a year. We just can't afford that. We can afford $8 a year, which is fine. So each one has to find what suits their budget and then create something which makes sense for all the stakeholders. I hope I answered your question. Thank you.
I think the difference with the US Obamacare is that in the case of India, this was very much an initiative of Manmohan Singh. He drove the process, and bulk of the funding actually comes from the union, i.e. the federal government, 75%, and there is a state-level contribution as well. Whereas in the US, so a bit like the Medicaid, really. And it's really targeting below poverty line individuals. It's for the poorest segments. So individuals or the businesses are not bearing the cost of the scheme. So I think that's a major difference. But the political enabler was that this was supported from the top. And another interesting example where there's been full expansion of insurance scheme recently is Turkey, where there was very cabinet-level support with green card scheme covering the poorer segments in the informal sector.
Yeah, I mean, I will adopt a more pragmatic approach. Do you want a blueprint before you get on with it, US? I mean, learning by doing, that is exactly what we have done. I mean, we agree that there's no blueprint, we were making mistakes on the way. So why not? To hell with it, go get on with it. That is the advice that we and our friends from Nigeria will tell you. Because, of course, you cannot have all the solutions before you start.
I must add, as a teaser, that if election in the Indian parliament or Ghanaian parliament will be every 2 years, I don't know if a program would have passed, as it is in the US.
Dr. Sebag, I think you should also give us a final answer to the issue of the role of the pharmaceutical industry in these efforts. You didn't have enough time to work it out.
You know, again, drugs, medicines are a part of development, a part of health, and we have some responsibility, some social responsibility. And access is important for us, is important for the people. And when you see that 70% of the worldwide population, they have to pay from their pocket the product, but also all the services, not only the medicines, we have to do something. Is our interest, is the interest of the other people. And I don't see here any conflict of interest, because some other company is doing the same. What we are doing in Benin or in Madagascar or even in India or tomorrow in Ghana is not for Sanofi products. The doctor we will choose, and we are not present in all around the world. I think, you know, time of polemics, we can going on polemics, the good in one side, the bad in another side, is finished this time. We are an actor of health, and we can bring something, and we have to work together in the philosophy of partnership. This is like that, and okay. If not, if we open always the umbrella, this bad pharma industry we don't want, I think it's not the world that I'm waiting for. And many people, you know, you can be on pharmaceutical industry and also to be in some NGO and to bring something. I think it's not incompatibility. Even in now they want to put people in one case, you are pharma industry, you are son of beach, and you are NGO, you are very good people. It's much more different, the life. And don't think that it be within pharma industries, people every day thinking how I can, for African people to get a lot of money. No, it's a common interest. The growth will come from the south. But we have to understand all together and to work all together. And I'm very happy to see Indian pharmaceutical company coming, a Chinese company, all if they respect a minimum of things. But don't kill innovation. We face, and all the countries of the world, we face the counterfeiting products. It's a main issue, the quality of the product. The counterfeiting products now are much more than drugs. It's a mafia, very important mafia. We know that. But if we don't give access to the people of good products, they're not going outside on the pavement to buy some counterfeiting products. I think it's our social responsibility. And more, and I will finish, the results of company are not only financial results or quantitative results, it's also qualitative results. We have to think with our environment. This is our social responsibility. And many people, they want to invest, cynically speaking. They want to invest in company if they follow social responsibility in terms of disability, in terms of diversity, in terms of access to medicine in developing countries, or many parameters, and they rank the company. And also this is our interest. With the globalization of information, everything has to be transparent, even if this industry, and to finish, what is the original sin of this industry is to make profit on life and death and suffering people. Mr. Gates is very good in Microsoft and car companies, they make profit. Everybody accepts, but make profit on health. Something wrong. But health has a cost. Even if it's no cost, is no price for health, health has a cost. And we are in the economical, but we have to find the way. And to find also some, with some organization, to find the way for access to the patient. This is a common interest for everybody. Sorry, I was a little long.
Thank you, but I think this was a very good conclusion already. We saw that the health financing issue is very complex. A World Health Report on health systems financing, which is only 2 years old, can't be the end of the route. And I think to exchange experiences, concrete experiences from national health systems, from microinsurance approaches, and from the impact of international global health financing instruments like Gavi and the Global Fund and UNITAID has to be brought together in each country or in each district together with the users and the providers of healthcare in order to have some positive effect. So let's close this evening, and thank you very much for the 5 contributors to this session. Thank you.
Thank you.